Hello and welcome to the recovery training about aspirin, baricitinib and colchicine. This is the current design of the recovery trial. Eligible patients, those who have been admitted to hospital with proven or suspected COVID-19, can enter 1, 2, 3 or all 4 of the randomizations shown on this page. Part A compares colchicine with usual care alone. Part B compares the Regeneron monoclonal antibody cocktail with usual care alone. Part C compares aspirin to usual care alone. Part D compares baricitinib to usual care alone. All patients are then followed to collect outcomes until the earliest of death, discharge, or 28 days later. Participants can enter as many of these comparisons as they are suitable for, that is, all those that are not contraindicated and that are available at their site. Aspirin is a commonly used antiplatelet with anti-inflammatory properties. The dose that has been selected in recovery is 150 mg once daily for the duration of admission. The main contraindications to aspirin are known hypersensitivity, recent major bleeding, or a bleeding risk for the participant that is considered too high by the responsible clinician. The main side effect of aspirin is bleeding, which is occasionally severe. We have chosen a dose of 150 mg within recovery because there is a potential risk of underdosing larger patients with a standard 75 mg dose, and the bleeding risk between these two doses is very little different. It is allowed according to the protocol to give patients gastroprotection if the prescribing doctor considers that necessary. It is also allowed that participants receive the standard thromboprophylaxis regime at their site, and how they are treated in accordance to that should not be modified by allocation in the trial to aspirin or control. Baricitinib is a licensed treatment for rheumatoid arthritis. It inhibits JAK1 and 2, which is part of the signaling mechanism for many cytokines, as shown in this figure. The JAK-STAT system transmits the signal from cytokines binding a receptor on the cell surface through to the nucleus, where they affect gene transcription. Baricitinib also inhibits tyrosine kinase, which has a similar function. Tyrosine kinase activity has recently been identified as a marker for severe COVID, so inhibition may be beneficial. Baricitinib was tested in the ACTT2 trial of 1,033 patients hospitalized with COVID-19 in the United States. They were randomized between baricitinib plus remdesivir or placebo plus remdesivir. The primary outcome for the trial was time to recovery, which was shortened with the addition of baricitinib by 1 day, so participants receiving baricitinib recovered 1 day earlier in 7 rather than 8 days. Secondary outcomes looked at mortality and the use of invasive mechanical ventilation, and encouraging signals were seen here. In terms of safety, baricitinib was very well tolerated, and in fact, serious adverse events were less common in participants allocated baricitinib compared to those allocated placebo. The main contraindications of baricitinib include pregnancy, an EGFR of less than 15, including those on dialysis or hemofiltration, a neutrophil count of less than 0.5, and current active tuberculosis infection. All women of childbearing potential entering recovery should have a pregnancy test. If they refuse this, or it is not available, they should not be entered into the baricitinib comparison. Because baricitinib is primarily excreted by the kidney, participants with suboptimal kidney function should have a reduced dose. For those with an eGFR between 30 and 60, a baricitinib dose of 2 mg once daily, that is, half the dose, should be used. In those with an eGFR between 15 and 30, 2 mg on alternate days should be used, or if 1 mg tablets are available, a dose of 1 mg once daily can also be used. The only significant drug-drug interaction for baricitinib is with probenecid, when the dose of baricitinib should be halved. Co-administration of baricitinib with tocilizumab is now allowed within the trial, given the increasing number of patients likely to receive tocilizumab as part of usual care. Both baricitinib and tocilizumab may increase the risk of other non-coronavirus infections. Giving both together might increase this risk further. However, this needs to be weighed up against the potential benefit of treatments in severely ill patients with a still significant mortality risk. Managing clinicians can exclude participants from this comparison if they feel the risk of other infections is too great. Additional safety information on non-coronavirus infections will be collected on the trial follow-up form in order to monitor the effects closely. The main adverse effects from baricitinib include infections, abdominal symptoms, including uncommonly diverticulitis, headaches, and rarely neutropenia or liver function test disturbance. Supplies of baricitinib are available for the trial through standard NHS stocks, but for participants given baricitinib, we would request a BlueTech form is completed, but this is kept very simple, so it will not take long and can hopefully be done by pharmacy colleagues. Colchicine is an anti-gout treatment that inhibits spindle formation in neutrophils and the NLRP3 inflammasome activation. So it is a powerful anti-inflammatory agent, which is commonly used for gout and pericarditis. There is increasing evidence of its benefits in cardiovascular disease, for example, in patients with previous myocardial infarction or those with chronic coronary artery disease. In recovery, participants receive a dose of colchicine of 1 mg as soon as possible after randomization, followed by a dose of 500 micrograms 12 hours later. Thereafter, they receive 500 micrograms twice daily for a total of 10 days or until discharge, if sooner. Colchicine can rarely cause cytopenias, so full blood count monitoring is recommended at a frequency at the clinician's discretion, for example, 3 and 7 days after randomization. Colchicine is teratogenic in animals, so again a pregnancy test is required. For women of childbearing potential who do not have a pregnancy test or who are pregnant, they should not be included in this comparison. Colchicine is also contraindicated in the presence of severe hepatic impairment, significant cytopenias at baseline, that is, a neutrophil count of less than 1, a platelet count of less than 50, and, if measured, a reticulocyte count of less than 20. Should also not be given with concomitant strong cytochrome P450 inhibitors or P-glycoprotein inhibitors. Further information about these are available in the protocol. Finally, it should not also be given to those with a hypersensitivity to lactose. In certain conditions, it remains appropriate to use colchicine, but at a reduced dose. By that, we mean giving the same loading dose regime of 1 mg followed by 500 micrograms 12 hours later, but then reducing the maintenance dose to 500 micrograms once a day rather than twice daily. The conditions in which the dose should be reduced include participants taking a moderate cytochrome P450 inhibitor. Again, more details are available in the protocol. Participants with a reduced kidney function, that is an eGFR of less than 30, and those with an estimated body weight of less than 70 kilos. If a participant has more than one of these factors, an investigator should consider excluding colchicine from the randomization. In other words, marking it as unsuitable on the randomization form. The main adverse effect of colchicine is diarrhea, which may limit tolerability. In this situation, it may be reasonable to try reducing the dose or stopping it completely if that is still not tolerated. Cytopenias are rare. Further information on the antibody-based treatments, including the Regeneron monoclonal antibody cocktail and the new early phase assessment of dimethyl fumarate, please see their individual training modules on the study website. Thank you very much for listening.